We have to stop politicizing healthcare. We need to have a more pragmatic approach, because realistically that's what our patients expect us to do, and that's what the taxpayer expects. It's very clear that taxpayers' money and taxpayer funds have to go where the evidence is, and only evidence-based treatment should be taxpayer and MBS funded. I think that's a common sense approach, so a review of our Medicare item numbers is long overdue.
There's between 5,500 and 6,000 that we hear are under review. Off the top of your head, are there any of those that you would say, well, that's kind of, that's leaching technology, not the good microsurgery kind, the kind of the pre-Dickensian kind? Are there things that shouldn't be there?
Look, healthcare has evolved over the last decade, and it always is evolving. So it's very clear that we need to look at what we are doing. Arthroscopies knee arthroscopies has been around in the discussion. 10 years ago, we felt that people, who had a torn meniscus all need to have an arthroscopy. Nowadays, we know that quite often a torn meniscus can repair itself after waiting for 6 months. So, rushing into an arthroscopy often doesn't make any sense, and probably therefore shouldn't be funded.
But what are the implications of that for somebody that may genuinely need an arthroscopy? Suddenly they're going to be paying a lot more for it, aren't they?
Absolutely, and if it's genuinely needed, I think there should be a Medicare item number again. It's just doing things unnecessarily, doing things too early, and doubling up on procedures, investigations that already have been done in general practice and primary care. Those are the things where there are obvious savings to be made, and those savings need to be redirected into the area where we can achieve better patient outcomes, and that is really primary care, that is general practice.
So where is some of the waste that you would identify as well? Some of the duplication, if not the unnecessary tests and procedures, where you might end up getting the same pathology done at the GP on a Tuesday as you then get at the inpatient clinic at the hospital on a Thursday.
Absolutely, that's a very valid point, and we need to make sure that the flow of communication between general practice and the hospital system and from the hospital back to general practice is efficient, and that doesn't work, unfortunately. Also, we have to be careful a bit. I've had a patient the other day who was seen by her gynecologist, and she complained of a headache, and the gynecologist ordered an MRI scan to investigate the headache. And of course, the gynecologist said, go back to your GP and discuss it with your GP. So, all doctors try to do the right thing by their patients, but sometimes it's just not the most efficient way to do, and sometimes it's just too expensive.
To what extent is this about patient expectations and dare I say, Dr. Google? People sort of saying, oh, I think I've got a brain tumour, you better check it out.
Yeah, look, patients are concerned. There's a lot of uncertainty out there, and people really don't know where to find the best information. You mentioned Dr. Google, you mentioned the internet, and that's why it's so important that GPs are playing a major part in communicating our patients' health. And that's why it's so important that, patients do have a GP they can relate to, and they can consult the GP whenever they have a health concern.
Let's get some questions and comments from the panel. Nick Cater.
Dr. Bastian, I wonder if you think there's any merit in looking at the fee-for-outcome model, which they've introduced under Obamacare, rather than what we now have, which of course is fee-for-service.
Yeah, look, it's probably really hard to just say, let's switch from one model to another. It's very clear from international experience, certainly from the UK, from Germany, and you mentioned the US, that the pay for performance doesn't actually save any money either. So it's going to be a hybrid model one way or the other. And look, realistically, the Royal Australian College of GP has proposed a new funding model, a new vision for funding general practice, and that certainly would be something we should be putting on the table and look at.
In the United States, I know that a lot of overservicing is driven by fear of legal action if something is missed. Is that also a concern among medical people here?
Look, I think that's the main driver. There is the saying, nobody has been sued for not investigating. But there are other areas as well. We all know about first do no harm. But in the 21st century, it's now almost first do no financial harm. There's also a financial component there that we need to be aware of. And I think that needs to be respected.